Next is about the Parkinson's disease. Now there are two terms which are used, like Parkinson's disease and Parkinsonism, or maybe Parkinson plus syndrome. These are the differences are, when we say Parkinson disease, there is a definite pathology which is related to the dopamine release. When you say Parkinson syndrome or Parkinson plus conditions, it suggests about the various conditions it can present with the similar clinical symptoms, but the pathology may not be exactly the same. Now, the first, of course, is Parkinson's disease. Now, it's considered to be one of the most common neurological disorder, affecting almost 1% of individuals older than 60 years throughout the world. So that it's a very common condition as such. And it's also called as idiopathic Parkinson disease, and it's supposed to be due to genetic and environmental factors. But exact environmental factors has yet been proved. The suspected factors are smoking, use of pesticides, living in a rural environment, consumption of well water, exposure to herbicides, proximity to industrial plants or quarries, caffeine intake. These are the supposed, maybe the argued the factors which can trigger the Parkinson's disease, but none of them is proved without doubt. Genetic factors are identified now, and genetic cause is identified in about 10% of the cases, particularly patients with the younger age having the clinical symptoms. Then another of the hypotheses which triggers the Parkinson's disease is a possibility of diabetes mellitus being a triggering factor. The other most accepted theory now is the oxidation hypothesis, or the later theory, latest of the theories, that active radicals or the free radicals which are present in the body as a result of metabolic defect, that may be the cause for the Parkinson's disease. And this theory, oxidation hypothesis or free radicals theory, is gaining more popularity now, and many of the recent trends in the treatment of Parkinson's disease also are directed to that level where the free radicals could be eradicated. Now, to understand the pathology of Parkinson's disease, the basic anatomy and the basic functions of the brain stem area particularly are mainly the subthalamic nuclei, and among the subthalamic nuclei, these putamen, globus pallidus are the two very major important nuclei which will have a control, which will be having control by the cortex. The input from the cortex, a motor input from the cortex, reaches to the globus pallidus, and the globus pallidus would have some inhibitory control, so that the actions would be very meaningful, and these actions, this inhibited control, would be reaching to the brain stem, and then the functions are achieved. Now, in the brain stem area, at that area, globus pallidus, there are multiple nuclei, ventral nuclei, lateral dorsal nuclei, and multiple nuclei are there. Each of these nuclei would have a specific function of regulating the activity and making the activity smooth. So the basic issue is the triggers, they are the ones which will having a inhibitory effect over the input from the cortex. See, cortex gives an impulse for the muscles to contract, but for the muscles to be remaining contracted and to contract to the optimum extent, which the function as required. See, that when I mean that optimum extent means, suppose if you have to carry a light object like a pen, the amount of the contraction of the muscle will be lesser. If you have to carry a weight of higher than that, like maybe 1 kg, the same muscles could be responsible, but the amount of the strength by the muscles is has to be increased. When you reach to another weight like 10 kg, again the same muscles could be contracted, but the amount of the contraction or the amount of the energy produced will be higher. Now, this regulation of these finer aspects of the muscle activity is done by the nuclei, which will have inhibitory control over and make the action smooth. And the major enzyme or major neurotransmitter secreted at that level is dopamine, and that dopamine is a major issue. Again the same, the functions are, the inputs are again presented in a graphical manner so that you can make out easily. From the cortex, the impulses reach to the putamen, and there will be again a feedback from the lower nuclei, and this whole circle in the normal phenomena would be having that activity. Whereas in case of Parkinson's disease, that impulses from the putamen would not be inhibited. These nuclei would be particularly substantia nigra, the nuclei in the substantia nigra area, just below the base of the brain, they would not be functioning properly, and hence it results in the lesions. Biochemical changes or maybe histological changes seen in the brain are mainly that dopaminergic neurons, either they are reduced in the substantia nigra area in a typical pathology of Parkinson's disease, either the numbers of dopaminergic nerves are reduced, or the amount of the dopamine which is released also would be lesser. Then another of the thing which is seen is if a histopathological section of the brain's tissue is seen, there are deposition of some blackish bodies which are called as Levy bodies in the neuritic, these nerve endings. These are the two pathological changes seen there. Clinical signs, the major three important clinical signs of Parkinson's disease are tremor, it is also resting tremor, tremor which is persisting in the resting condition too, which we also call as unintentional tremor. And the tremor would be usually having a repetitive character, the same movement is repeated, and when the tremor occurs in the hands, it gives an impression of the thumb rolling over the other fingers, which is also called as pill rolling movement. So that kind of tremor is very classical and it's a cardinal sign. Then the other is rigidity, and rigidity of the muscles, particularly the thicker muscles of the body, and hence the patient would have a typical gait. And then bradykinesia, the total movement would be slower. All the movements, they tend to become slower, and maybe the purpose would be affected. These are the major three clinical signs of the Parkinson's disease. The clinical symptoms would be quite wide varying. Though we consider these are the three cardinal signs, the presence of the clinical symptoms in patients of Parkinson's disease could be wide varying, and because of this wide varying and vast presentation, exact diagnosis often becomes difficult. The symptoms which are produced are initially, the clinical symptoms could be tremor is the usually initial clinical symptom, or patient may have a difficulty in doing finer jobs. That's what called as the decrease in the dexterity. Say finer jobs like inserting a thread into the needle, writing or drawing a picture, so on. So such finer jobs, the person would feel that he is not able to do the same fine activity which he was doing earlier, and there is some feeling of tremors, particularly when he does such finer jobs. Or it could be like buttoning the shirt and so on, next level of the jobs. Finer jobs like writing and fine arts is the first thing. Next is relatively less finer job like and which is done regularly, like closing the button or opening the button of the shirt and so on. And most of the times the condition would be presented in one side, particularly the dominant side. Those who are dominant on right side, it will be seen on the right hand, and or maybe in the left hand. That's the most common, but some of the patients may have bilateral symptoms too. Then the patient's other clinical symptom will be when the patient walks, the swing of the arm would be reduced, and again there would be a comparison changes in the one side. The arm on one side would be having lesser swing, and that gives again a typical appearance in when the patient walks. That could be the initial symptoms. Another of the clinical symptom can be the changes in the voice. The voice becomes somewhat softer, the characteristic voice would be affected, and this can also affect these professionals like singing, teaching, etc., where the voice can be affected. Then the other clinical symptom could be facial expression would be reduced. See, the facial expression requires very fine control of the facial muscles, and this also becomes reduced. And this also may be something which is noted by somebody else. The patient may not note it, but the patient, somebody else may be noting it, seeing as maybe at times it could be interpreted as a mood changes in that person. And sleep disturbances, particularly sleep disturbances with the rapid eye movement, would be lesser. Then the patient also would have an abnormality of what we call as the typical rapid eye movement even in the awake conditions, and this results in a behavioral disorder. The patient looks like here and there, and it looks like the patient has some behavioral disorder, and this is also called as a rapid behavioral disorder, and which also can result in a tone of the muscles being reduced. And the same also can occur during the sleep. In the sleep you have two stages, REM and NREM, rapid eye movement sleep and NREM sleep. During the REM sleep, the patient may have some reduced tone, and hence during sleep, at that moment of getting into sleep, during the REM stage, the patient may feel like, or maybe kicking, hitting, talking, crying, and so on. So which also may be considered as something like the dreams which are acted. So that's also the other clinical symptom. Again, this symptom also may be noted by somebody else, not the patient by himself. Sense of smell may be the decreased one, which is also one of the initial clinical symptoms seen in Parkinson's disease. Then symptoms of autonomic dysfunction like constipation, sweating abnormalities, sexual dysfunction, dermatitis, these also can occur in the patients of Parkinson's disease in the beginning. A general feeling of weakness, malaise or lassitude, depression, which also can be presented as a psychological issue. Anhedonia is where the patient is not able to concentrate and the patient is not able to think properly as earlier. It looks like a slowness of thinking, which also could be the clinical symptom. Because of these vague clinical symptoms, early diagnosis of Parkinson's disease is often difficult. Then usually the initial clinical symptoms are can prolong for quite a long time. It may take about 3 to 4 months or even 6 months. At times it could be years to present with a prominent clinical signs. A typical Parkinson's disease takes a longer time for the onset, whereas what we call as a Parkinson plus syndromes, there could be a shorter course as such. Now, onset of motor signal signs would occur usually after a prolonged duration, which can vary from a few months to a few years occasionally. And when the motor symptoms do occur, it is typically asymmetric, like it may be limited to one side, may not be equal on both the sides. And the resting tremor is the initial and most of the times it starts with the upper extremity. Then gradually it becomes bradykinesia, where the patient would find a slower movement, there would be rigidity, and the gait will be difficult. Postures of the body also would be affected. Patient tends to flex forwards, and it looks like as if the patient is walking faster. Every step it looks like patient walks faster because he is not able to maintain the position against the gravity, and that postural instability results in a typical walk where the patient bends forwards and then moves in the faster and faster steps. And when the patient moves in a corner, when he has to change the direction, again he will be finding very difficulty. Many times the patient may hit and then he may change the direction. Non-motor symptoms like forgetfulness, saliva, urinary urgency, hyposmia, constipation can become more prominent. Typical Parkinson's gait is very typical, where the patient would have a stooped posture or bending forwards. The face would be masked, like in the sense the expression would be not seen. The trunk would be bent forward. Rigidity, the back would be rigid as such. The arms look like having flexion at the wrist, the elbow and the wrist area. And the hand tremors are classical. As I told you, the hand tremors are typical, which is presented with that typical pill rolling type of the movements. The short stepped gait, the gait would be having shorter steps but faster, and that's the typical appearance of a Parkinson's disease. For this presentation to occur, where the clinical evidence is seen, it takes usually a longer time. Now, because it takes a longer time, it's also difficult to make out the conditions. There is a classical method of what we call as a phasing of the Parkinson's disease depending upon the involvement of the area. Initially, it's related to the dorsal motor nuclei, and when the dorsal motor nuclei are involved, it doesn't produce any significant clinical symptoms till the substantia nigra is involved. See, there is a gradual involvement, increase in the involvement, step by step. Initially, it's the dorsal motor nuclei which are involved. Then it becomes the gain setting nuclei, that's at the base. And see, actually, it starts at this level and it moves upwards. And then substantia nigra is involved. Then the clinical symptoms will be started. Till then, the clinical symptoms would not be seen as prominent. There could be early clinical symptoms, but then it becomes faster. And when the primary neocortex, that the cerebral cortex, uppermost area, is involved, then the patient would have the personality changes, behavioral changes, and so on. So that's how the clinical symptoms are evolved. Now, because of this, the staging of Parkinson's disease is a very complex phenomenon, and there are many staging systems which are used. Most common used is a hen-hair staging system, which is more common throughout popularly, and it is staged into 5 stages, exactly in the same, based upon the same principle of involvement of the different nuclei. Stage 1 is the earliest stage, which includes mild tremors, mild difficulty in walking, and it affects only one side of the body, and most of the times the patient's family would be noting the changes than really the patient observing anything, and the patient's daily life is not affected. Patient would be doing all his normal daily activities as such. Then stage 2 is symptoms worsen and tremors and difficulty moving now both the sides of the body. Then daily tasks are more difficult but still possible to complete independently. That's what we call as stage 2. Stage 3 is when the patient finds it difficult to maintain the balance and coordination. And that balance, till that condition, most of the times patient's daily activity would be normal. The patient would be able to do the normal day-to-day activities. In the stage 3, the patient would find it difficult to maintain the balance, and often it could be a falls at maybe at corners, and it may be a big issue, and the patient may need some assistance like dressing, feeding, etc. Stage 4 is the tasks become more difficult. Walking aids may be necessary, and patient may not be able to walk or do his normal activities on his own. He needs help for majority of the tasks which are to be done daily. Then stage 5 is the most severe stage, where the patient would find it difficult to stand and walk even with the help, and most of the times the patient would be on wheelchair or bedbound, and the patient may have hallucinations, delusions, and so on. So this is how it is staged. So Parkinson's disease is staged based upon the severity of the clinical symptoms, and the most common staging system is a hen-hair staging system. Now there is a atypical Parkinsonism. Parkinsonism may present with atypical presentation, as I told you, which can occasionally occur, and in that atypical Parkinsonism, instead of this kind of a evolution of the clinical symptoms, patient may start with the symptom of falls at the presentation, at the early stage itself. And of course, the other atypical Parkinsonism is when you treat the patient with the classical treatment of levodopa, if there is no response, that's also called as atypical Parkinsonism, or we will be referring to another issue, the Parkinson plus syndrome. At that condition also, it's called as atypical. Then symmetry at disease onset. So usually the symptoms started on one side and then progress to the other side. Whereas if the patient has a typical involvement or a similar involvement on both the sides, then it's considered as atypical Parkinsonism. If the disease progresses rapidly, within 2 to 3 months the patient develops the severe clinical symptoms, then also it's called as atypical. And if the patient presents with no tremors but other symptoms are there, then also it's considered as atypical. When the patient presents with the autonomic symptoms in the beginning itself, like urinary incontinence, fecal incontinence, catheterization for urinary retention, persistent erectile failure, or symptomatic orthostatic hypotension, these can also be the atypical Parkinsonism, which are comparatively rare. Diagnosis of Parkinsonism is again quite difficult. The imaging studies do not confirm the Parkinson's disease. Only rarely you may find certain of the features in the imaging studies. MRI is considered to be better than the CT scan to make the diagnosis. MRI findings also could be of different variety. Like it also depends upon the type of the technique of MRI by which you can find the changes. Like, see, if the better technique would be a T2 flare technique, where there could be the abnormalities could be seen somewhat better as such, and hence usually when you refer a patient for patient of suspected Parkinson's disease for MRI, it's better to write specific T2 flare technique as the technique which is preferred than the other way. The findings which are seen are mainly compared to normal. See, this is lower figure is the normal MRI scan, whereas in the MRI, the usual MRI scan as such, you will see that the the nucleus putamen area will become widened, and the ventricles, they become somewhat narrower, and edema could be the initial sign which is seen as a flare, whiter flare as such. That is the MRI findings. Or in the advanced stages of MRI, it may be seen as these shadows which are having that bulbar appearance. It's also called as the donor appearance, that where there will be a round circle-like lesion just at the base of the thalamus, which also can be the evidence there. And it's also called as the hummingbird sign, where at the area of the putamen seems to be sharper, angle of the putamen will become wider, and this gives it's also called as a hummingbird sign in radiology. That's about the MRI signing. Another very sophisticated technique, which is somewhat more specific to make the diagnosis of Parkinson's disease, facilities are not available everywhere, is DAT scan. DAT scan is considered to be one of the standard investigational tools than the MRI or the CT. MRI or CT has a lesser sensitivity. And DAT scan is also called as dopamine transporter scan, one of the this modified PET scan, where the changes in the metabolic activity, changes in the dopamine secretion can be made out. But of course, in our practical clinical situation, you do not have the facility of DAT scan in the nearby areas. Only in NIMHANS in Bangalore, they have the DAT scan here in Karnataka, I think. In other centers, I am not very sure, but in nearby centers, there are no such facilities available. And another of the option is a PET scan. PET scan has a higher sensitivity and more specificity. Particularly in the PET scan, the glucose metabolism in the brain area can be made out. And in case of Parkinson's disease, that reduced glucose metabolic activity can be made out easily, and this also is considered one of the standard tool for making the diagnosis of Parkinson's disease. Now, as far as the treatment is concerned, there is no curative treatment for Parkinson's disease. Such a curative treatment is still not possible. The medical treatment is mainly the levodopa. Levodopa is considered as the standard treatment for Parkinson's disease. Usually what happens is with the levodopa, the short-term benefits are very significant. As you start with the levodopa, the initial benefits are very significant. But in the long run, there will be a wearing off of the effect. And once the patient wearing off of the effect, in the sense the patient may not have the same benefits as earlier. And at that stage, even if you increase the dose, the patient may not have the same effect. Rather, at times what happens is when you increase the dose, the condition becomes worse. And that's the situation where usually the patients come for early treatment. Another group of the drugs which are usually given are monoamine oxidase inhibitors like seraglutide, which help in reducing the psychiatric symptoms like depression, and maybe the rigidity also is reduced with the same treatment as such. These are the usual medical treatment. The other advanced treatment which are coming up now, which are now getting recognition and which are becoming popular, are mainly the deep brain stimulation. Deep brain stimulation is a stereotactic surgical procedure where it's a minimal invasive surgical procedure where it stimulates the deeper brain centers for a long duration, which makes the brain active, nerve tissues active, and the benefits are supposed to be for a longer duration. The facilities are available only in very sophisticated neurological centers. In nearby hospitals you do not have. Again, as I told you, NIMHANS in Bangalore has that facility, deep brain stimulation center. Maybe that's considered as a very beneficial, and many of the patients who have very significant benefits seen and lasting for quite a long time, 3 to 4 years, 5 years, and so on. The other surgical approaches are the thalamotomy or pallidotomy. This was earlier practiced more frequently. Now the thalamotomy, surgical involvement of or surgical resection of part of the thalamus, was practiced earlier, or globus pallidus also was done earlier, but these days that kind of surgery is becoming less popular. Another is the neural transplantation. Now about the neural transplantation, history is quite interesting. The first experiment of the neural transplantation was done in India, in All India Institute of Medical Science, by transplanting monkey's brain tissue over to the patients as such, and it found to be quite beneficial. And now, of course, very recently, globally, this technique has got the recognition, and very few centers throughout the world are there where such facilities are available, and it is claimed to be very beneficial. Another very advanced therapy which could be considered to be the treatment of the future would be gene therapy, where the genes could be modified. Now, from Ayurvedic point of view, based upon the clinical experience which I have seen, the combination of Smritisagara, Ekam, Veera, Abhrakatapyadi Mishtana with the Tailadhara and Rajayapan can produce some benefits. Patients, if they are on levodopa, it's better not to stop the levodopa. Along with the levodopa, these medicines given can help in a significant resolution of the clinical symptoms. Patient's life, quality of life can improve, though there is no question of cure. Another important observation which I have made is treatment like Pindasveta worsens the condition. That's one of the significant thing which you have to keep in mind when you treat the patients of Parkinson's disease. Then comes the next, Parkinson plus syndromes. Now, Parkinson plus syndromes also are quite troublesome from the clinical point of view, because they present with the similar clinical symptoms, and the conventional treatment of levodopa fails to produce the clinical condition, and it's usually we use the name Parkinsonism, not Parkinson disease. So either Parkinson plus syndrome or Parkinsonism is the other term which is used, where the patient presents with the rigidity, tremor, and so on. But unlike that of a typical Parkinson's disease, the clinical presentation may be presented with these variations. The variations could be early onset of dementia. Within a short duration of the clinical symptoms, a patient may have dementia. Or early onset of postural stability, which is generally considered as the stage 5 in Parkinson's disease, may occur at the early stage. Or early onset of psychosis unrelated to medication or side effects as such. Ocular signs, where the patient may have a vertical gaze or square wave jerks, nystagmus, blepharospasm, that's or apraxia of eyelid, where the patient may not be able to close and move the eyelids properly, which also can be the presentation. Pyramidal tract signs, which are not provoked by previous strokes or spinal cord lesions. Now, when I say pyramidal tract signs, one of the other common clinical condition which we see is the pyramidal tract signs produced as a complication of psychiatric drugs. Many of the psychiatric drugs would have an impact on the pyramidal tract, and that extrapyramidal tract symptoms as well as pyramidal tract symptoms can occur in such patients. When we say pyramidal tract signs, it means where the voluntary activity will be affected, not only in the patients with the these tremors and involuntary activity, and this also is a variable and variant of the Parkinson's disease. It's also called as a Parkinson plus syndrome. And autonomic symptoms which are very severe can result in postural hypotension and urinary incontinence in the early course of the disease. And motor apraxia, where the patient is not able to control the movement in the proper manner, symmetry when the symptoms are presented equally on both the sides, that is considered as a Parkinson plus syndrome. Now, from the current knowledge point of view, with the advanced studies, the Parkinson plus syndromes now are identified with some variants based upon the pathological presentation. Now, of course, the ultimate advantage of going into these classifications and the details would be of lesser importance from the routine clinical point of view, but from the academic point of view, these have some significant advantage. The variants are either multiple systemic atrophy, or which is also called as MSA. Multiple systemic atrophy is a condition of progressive degeneration occurring in adulthood and manifesting with the autonomic failure, that same typical Parkinsonism, cerebellar dysfunction, and pyramidal signs which are not responding to levodopa. See, the whole issue is one group of the patients which present with similar clinical symptoms, but the patient would not respond to the levodopa. These are the multiple system atrophy conditions. Of course, an objective confirmation of multiple systemic atrophy would be by the investigations would be difficult, and it's only the PET scan which can make out that difference. Otherwise, all the other investigations may fail to make out the diagnosis. So, from the routine clinical point of view, these differences would be of lesser importance. But the only importance is those conditions which respond to the levodopa, and those conditions which are not responding to levodopa would be a better classification. But still, from the clinical point of view, you need to have some idea of this, because when you come across with these terms, you should not be confused. Then another variety which is identified is a progressive supranuclear palsy, which is considered to be a pathology related to a specific protein, microtubule associated protein disorder, which is again presents with the postural instability leading to frequent falls, bradykinesia, rigidity, dysarthria, and frontal lobe dementia. And again, an exact diagnosis is possible in a very high sophisticated centers only with the either DAT scan or PET scan. Otherwise, it may not be possible to differentiate that. Then corticobasal degeneration is another of the condition which can present with the standard clinical symptoms of what we call as useless arm. Patient may not be able to do the functions of the arm. Gait disorders, prominent sensory symptoms including where the patient is not able to identify the shape of an object when the eyes are closed. Astereogenesis is the shape of an object may not be identified. Speech disturbances or behavioral psychiatric disturbances, that's a type of corticobasal degeneration. Then dementia with the Lewy bodies or DLB is another of the variant, which is a progressive degenerative dementia of unknown etiology. The patient may present with the dementia as a clinical presentation in such conditions, and motor signs develop later. Again, most of these conditions are often misdiagnosed as maybe the psychiatric disorders and so on. Then Parkinsonism, dementia, ALS complex. Dietary toxins in native flora, that's in the food, is considered to be one of the causes, and in some African countries this was identified and established, and by changing that toxins, the food habit of that community, the incidence has been reduced. That's all the variant history of this. But from practical clinical point of view, these variants are not much significantly important. So that's about the Parkinson's disease and Parkinson plus syndrome. As far as the treatment for Parkinson plus syndrome is concerned, from our point of view, there is no other curative treatment. All the treatment would be a symptomatic treatment as such. Even from the contemporary science point of view, there is no curative treatment for Parkinson plus syndromes. It is only at present, there is only the same treatment protocol is considered as that of the treatment for Parkinson's, and the outcome would be poor. Now, the next condition which we discuss would be multiple sclerosis. I think. Multiple sclerosis is a big, somewhat bigger chapter. Okay, we will continue. Multiple sclerosis is an immune-mediated inflammatory disease that attacks myelinated axons, that is large neurons are involved, and characteristically it is the myelin sheath which are involved due to the autoimmune pathology, and it results in the axons remain intact till very late stages, and because of the loss of myelin, the functions of the nerves would be affected. Classically, the clinical symptoms would occur in episodes. There would be one episode of the neurological symptoms, then there is a spontaneous recovery, again there could be another attack, and during each attack like symptoms, there would be some residual symptoms which can result in ultimately a debility as such. The demyelination mechanism now is considered to be due to these lymphocytes, T lymphocytes which are present there as a medium of autoimmune disorder, and they enter into the myelin sheath and produce this area. T and B cells would be present over that area. Particularly T cells, they produce the cytokines which can interfere with the functions of the myelin. The incidence is quite common. Approximately 2.1 million people are affected by this multiple sclerosis. Female to male ratio of this multiple sclerosis has changed in the last few years. In 1955, it was 1:4. More number of males were affected than the females. But now in 2000, it is 2:3. The number of females getting involved is also increasing. So ratio has become changed. Reasons it's not known, but usually it's supposed to be change in the lifestyle as such. Then usually it's diagnosed in the younger age, in between age of 15 to 45 years, but it can occur at any age, and the average age of diagnosis is at around 21 years to 30 years in female. So that's important is because it's a disease which is identified at a very young and active phase of the life, and that makes it more sensitive. The exact cause of multiple sclerosis is not known, but evidences are related to genetic and molecular factors. A specific gene now is identified. It also could be a result of viral infection. Post-viral infections are these sclerosis are common, and very recent data says that after the COVID, the instances of multiple sclerosis are increasing as such. That's so it could be related to either the COVID or COVID vaccine is another controversial issue. Environmental factors like southernmost part and northernmost areas have comparatively more incidence of multiple sclerosis than the equatorial area. Vitamin D levels also is supposed to be one of the causes, again controversial. And cerebrospinal venous insufficiency, patients who have vascular pathologies also could be another of the cause, but it's controversial. Hepatitis B vaccine also is claimed to be one of the factors which can induce multiple sclerosis, but this also has become controversial. Lots of debates are there, lots of pro and the against views are there, so we'll limit only to that. From the clinical point of view, multiple sclerosis is classified into three categories based upon the clinical presentation as a spinal, myocardial or optic neuritis conditions. Of course, a patient may present with all the three category symptoms, or some of the patients may present with the exclusive one symptoms depending upon the area involved. Spinal condition is where the spinal cord lesions are produced, which are more common, particularly in India. When we see our patients, majority of the patients are of spinal sclerosis conditions, where the involvement is 55 to 75% of the patients, and either it could be in the beginning or the spinal symptoms may occur later during the course of the disease. And the important is in that condition, your evidences, radiological evidences are seen only in the spinal cord. Myocardial is another subtype where it was actually, this subtype is added very recently in 2018. It is presented with the spinal cord demyelination as well as the cerebral cortex demyelination. Optic neuritis is the most other common clinical symptom which is often presented, where the patients present with the optic neuritis symptoms and they develop these symptoms at least once during the course of the disease. The clinical presentation would be varying depending upon the type of these multiple sclerosis. The classical symptoms which are present, and one of the most important characteristics is exacerbations and remissions. Episodes occur, months or years apart. In between the gap could be months or years. It can occur at different locations. Now, the classic symptoms would be presented with the sensory loss initially and usually an early complaint at some areas of the body. The sensory loss, particularly this is true in spinal cord pathologies. And the spinal cord symptoms are the motor symptoms like muscle cramps, which also can result in spasticity, also can occur as symptoms. Then autonomic symptoms like bladder, bowel control, sexual dysfunction could be the other symptoms. So initial symptoms are vague, which would be difficult to make out the diagnosis. Then comes the cerebellar symptoms, where the patient have the symptoms of dysarthria, nystagmus and intention tremors, which may produce confusion with the other extrapyramidal lesions. Cerebellar symptoms are the other conditions which can occur in case of multiple sclerosis. Optic neuritis also is another of the most common clinical presentation, where the patient would be presented either loss of vision or impaired vision, particularly color vision will be affected, and then pain in the movement of the eye also could be represented as such, or patient may have the phosphenes. Developing phosphenes is a presence of a transient flashes or light like squares in the visual field. Trigeminal neuralgia can also be another of the clinical presentation, where the patient, it could be again bilateral trigeminal neuralgia with the weakness of the facial muscles and irregular twitching of the facial muscles, which is also called as myoclonus. Twitching of the facial muscles could be the clinical symptoms of multiple sclerosis, also may be a presenting symptom, and a good number of patients present with this kind of symptoms also. Eye symptoms like diplopia and lateral gaze, looking at the other side, also could be the other presentation, which occurs in about 33% of the patients. Heat tolerance, intolerance is the other conditions. Then constitutional symptoms like fatigue, which is seen very commonly in more than 70% of the patients, dizziness, and from the clinical point of view, this fatigue has to be differentiated from psychiatric factors like depression, which may coexist, or exertional exhaustion due to disabilities. Right? Then pain is seen in 30 to 50% of the patients at some point of their disease. Cognitive difficulties, where the patient is not able to give or perceive is not able to concentrate, may have an effect, impaired memory, impaired judgment, also can the other symptoms. Depression, euphoria, bipolar disorders, which may also may be wrongly diagnosed as psychiatric diseases, can occur in patients of multiple sclerosis. With the patients may present with the acute transverse myelitis like conditions also, or aphasia also can occur. Seizures, which are quite dangerous conditions in case of multiple sclerosis in 5% of the patients. Paroxysmal symptoms like ataxia, akinesia, paresthesia or pruritus or motor complaints without sensory deficits also may occur, but they are comparatively rare, and particularly seizures when they occur, that suggests of a poor prognosis. Now, fatigue as a clinical symptom is the most other significant symptom as such. Spasticity is the other symptom. Cognitive dysfunctions, like a patient is not able to comprehend, give an attention, visual perception, planning, problem solving. So, all of this may be again diagnosed as a personality disorders as such. The main signs are localized weakness, some area, or focal sensory disturbances, some areas sensory disturbances, and hyperactive reflexes with clonus in ankles and typical upper motor neuron features like, and increased tone are the velocity dependent passive range of motion. Like when I say velocity dependent passive range of motion, in the sense when you ask the patient to raise the hand, or when you raise the hand up, if you raise it slowly it can be raised up, but when you raise it rapidly, faster, he cannot raise up. So that's how it can occur. And the ophthalmic examination can show reduced activity or signs of uveitis, vitritis or vascular sheeting as such. There could be a increased blood flow over the retina, which could be seen in fundoscopy. Papillary hemorrhages also can occur as such. Diagnosis is mainly by a typical history, which is the most important thing. Then oligoclonal bands in CSF. The other diagnosis is a cerebrospinal fluid is subjected to the electrophoresis, where you see that clonal bands are, or immunoglobulin G in serum also is another supportive factors. Visual evoked potentials like the patient visual examination, when the patient doesn't have the typical response of the eye movements when there is a light thrown on the eyes. The most important otherwise dependable is MRI imaging, which is asset, and when there are no other possible diagnoses, then the diagnosis is made. Because the diagnosis is difficult, there is a standard protocol of what you call as McDonald criteria for this multiple sclerosis diagnosis, which again gives you some clue like when you have to go for MRI scan and when you do not need to go for. When the patient has 2 or more attacks and there is a clinical evidence of localized lesions somewhere, there is no need to go for any other evidences. It can be made as a diagnosed as a multiple sclerosis, but MRI has to be done. When the patient has objective clinical lesions in at least one area and 2 or more attacks, then also MRI may be necessary, but MRI even you can wait for another a few days and another clinical attack, then MRI may be done. Like if the patient has one attack and then objective clinical evidence of 2 or more lesions, then in that condition MRI is a must along with the CSF specific diagnostic assets. CSF may be necessary to confirm the diagnosis. If the patient has one attack and objective evidence is of one lesion, then along with the MRI and CSF study, you have to maybe it has to be waited for the diagnosis. Then insidious neurological progression is if the patient has a disease which is persisting for more a year, and in the CSF, if the MRI scan shows the lesions of the increased flare, then it can be made as a diagnosis. Investigations, actually CT was considered to be a standard diagnosis features suggestive of the myelination, where the plaques could be seen, that dense plaques could be seen in the CT, and brain atrophy also may be seen as such in case of CT findings. So earlier CT was considered to be standard, but now MRI flare technique is considered to be standard, where the MRI lesions are hyperintense lesions are seen in the MRI, very dense lesions are seen, and or there could be what we call as a dot dash sign, as you see multiple dots and these lines like which is again our dot dash sign. Here the dots of that intensity dashes like signs also are seen, and MRI is considered to be, or even the same is seen in the spinal cord also. Spinal cord, you can see that dots and dashes. Hyperintense lesions could be seen in the MRI. So comparison of CT and MRI is now considered to be better tool than the CT. Classification of this again, it's more from the theory point of view. I think we can skip this. The common type of the presentation is what we call as relapsing remitting MRS or multiple sclerosis, which is seen in about 85% of cases, which can present with either a single episode of neurological symptoms or where the patient may have a complete remission after the condition. Relapses may occur after a long time, and the physical disability may not occur at the early stage. The other types are secondary progressive. Primary, I think we can skip this because it is not clinically very important. Then the other important issue is if the condition is not treated, more than 30% of the patients with the sclerosis will develop significant physical disability within 20 to 25 years after the onset. So the whole course is quite prolonged, and less than 5 to 10% of the patients have clinically milder phenotype in which no significant physical disability accumulates despite the passage of several decades, and they may have a proper life as such. So the identification will be difficult in such conditions. As far as the genetic condition is concerned, the genetic identification is concerned, there are no specific genes which are identified to be responsible for the multiple sclerosis, but a gene which is responsible for preventing this multiple sclerosis is identified, and those patients who have that kind of a phenotype where the genes are having that inhibitory effect, they will not have these clinical symptoms as such. Now, From the clinical assessment point of view, in a patient of sclerosis, the disability has to be assessed, and the disability is assessed by usually the standard expanded disability status scale, which is common for all. I think which is important from medical legal point of view. Whenever a patient comes with some disability, to decide about the compensation, this is done. I think we can skip this today. Maybe on some other day again we refer to this issue. Expanded disability status scale, the grades are there, about 10 grades are there. Now, treatment for the multiple sclerosis is again depending upon the stage in which you have seen the patient. For the acute relapse condition, it is a methylprednisolone, which is considered to be the standard treatment now, and which can help in acute exacerbation. Recovery from the acute exacerbation can occur, and that's a stage where we cannot do much from our Ayurvedic point of view. When the patient presents the acute episode, essentially it has to be methylprednisolone or the plasma extent, plasmapheresis. Dexamethasone also is often used in transfusion myelitis like presentations. Then the patient is maintained after the acute attack. The patient is maintained with the different sorts of the drugs like interferons or the sphingostin phosphates like cyclophosphamide. This is a common prescription which are given, or monoclonal antibodies. Now these days, these monoclonal antibodies like natalizumab is becoming more popular now than the others. Or immunomodulators also are now prescribed as the suppressants to prevent this. Then the other drugs which are used are mainly from the symptomatic management. For the fatigue symptom, amantadine is given. For depression, serotonin uptake inhibitors like citalopram is prescribed. There are spasticity, baclofen is often prescribed. And for the pain, tricyclic antidepressants are prescribed. And optic neuritis, IV methylprednisolone are prescribed. The importance of these would be because many of the patients who come to Ayurvedic hospitals, they come with these medicines. Now, to decide like which of the medicines can be stopped, which of the medicines can be continued, should be continued, I think this information is necessary. Depending upon the type of the prescription given to the patient and purpose of the prescription is necessary, and you can manage that. Now, from my experience, clinical point of view, multiple sclerosis patients, when they present with the clinical symptoms as such, for the clinical symptoms of pain and spasticity, we can avoid those tricyclic antidepressants as such, and we can manage the patients with the Smithsagarasa, which can be quite effective. For the spasticity, Ekavigarasa can replace the other drugs like baclofen can be easily replaced with the spasticity. For the fatigue symptoms, Chandraprabha and Ashwagandha can be used. For optic neuritis, I am not sure, but I would be prescribing Triphalachurna at night with Madhu and Gatra. But the dexamethasone or steroids, if they are being given, I would still continue. I will not stop these because the visual symptoms would be quite these troublesome. Whether it can prevent the consequent attacks or not, again question mark. I am not sure about it. But we have treated a patient, large number of patients with Agni and Makrabasti, and as it's not predictable, like when the patient would have another attack, we can claim that our treatment, and many of the patients, they might not have developed another attack after still a long time, but whether it's really due to this treatment or not is still questionable, but this is how I deal with the patients. With this, we'll conclude today. If there are any questions, I will try to answer, and then there are no questions, right. So we'll conclude today.